Alright guys, welcome to episode 78 of the unofficial NCLEX Podcast. My name is Katie Kleber and I am your host. The title of today's episode is Assess Appropriateness of the Type of Restraint or Safety Device Used. This begins the first of 3 episodes related to restraints or safety devices. So before we restrain or implement a safety device, we want to make sure that we've tried everything else first. So what are some alternatives that we can try? Sometimes it's very helpful having a family or friend at the bedside. The challenge with this one is if it's just one person, they have to go to the bathroom sometime. They have to go get something to eat. And they may not always communicate that to you. So you really have to have very clear communication if you have a confused or patient that may need restraints, and we're utilizing family and friends to prevent that. But we got to make sure that they understand that they just can't leave. Like, we have to have a plan for when they're not there. Bed alarms is a good alternative. If you notice someone gets really agitated and hops out of bed, whenever they have to pee, maybe routinely toileting them before that happens. Promoting relaxation, maybe draw the shades down, calm music, a good friend there, whatever. Provide familiar material, so maybe a family picture on the bedside table. Reorient the patient. Address any pain, nausea, or anxiety. That stuff can really make somebody be in a situation where they need need restraints. So we got to make sure those needs are being addressed. Rounding on them, checking on them frequently, ambulating regularly, utilizing a sitter. That's a great one, but it's not always the first option because that is, another staff member, so that's pretty costly. So if we could use another alternative, that would be helpful, but sitters are wonderful. We also want to explain care before providing. So if the patient is confused and kind of wanting to hop out of bed and they're difficult to control, and they've got insulin due, you don't just run in and stab them with your insulin needle. You got to make sure, hey, Mr. Smith, remember me? I'm Katie. I'm your nurse. You're here because you had a stroke. We checked your blood sugar and it was a little high, so I'm going to be giving you some insulin, and then explaining that before they even see the needle. Things like that, the more... that way they don't feel paranoid or like people are coming in and doing stuff, and maybe take some extra time to explain some things. A room near the nurse's station is a great option. So it's important that we're making sure we're checking out all of our alternatives. And some are pretty effective. Distraction is a great one. Maybe you've got the confused person that just keeps getting out of bed in the middle of the night or in the middle of the day, and maybe they just need something to do with their hands. The Alzheimer's patient that needs to fold towels. We've done that before, and that's been wonderful. And have them sit up at the nurse's station, instead of having them tied down to the bed. Let's give them a little leeway. I had a patient once walked in. He had a sitter. He had a posy vest and restraints, and 6'5", real muscular. I think he had some sort of neuro issue, and I cannot remember what it was. But, I was like, man, these restraints, I think we're making him worse. So with public safety by me, I took the restraints off and, talked to him pretty calmly, asked him about, not stuff related to you need to do this and you need to do. I wasn't going to get in a power struggle with him. I just talked to him, and we got him a sitter, and the sitter was nice and sassy with him, and he liked that. And we ended up not needing restraints. He just needed a little leeway, and he needed people coming in the room that weren't just coming in to do something, to give him an injection, to force him to take meds. It just, approaching it differently enabled us to remove the restraints, which was really helpful. So it helps to be able to read situations. Another thing that's important to understand is the difference between chemical versus physical restraints. So a physical restraint restricts movements with a specific device. Let me give you some examples. A posy vest. So that's a vest their arms go through it, short sleeve, kind of sits, I don't know, about navel, depending upon how large the patient is. But under the armpits, there are straps that strap to the bed. So basically it kind of holds them to the bed. And that's helpful for a patient that is trying to get out of bed with their chest and not really messing around with their hands at all, or we don't need to worry about them pulling out IVs. We just are worried about them standing up and getting up. A soft wrist restraint goes around the wrist, bilateral, both wrists, like bracelets, but they're soft, so they theoretically shouldn't cause harm, and they're tied under the bed. Soft hand mittens, exactly what it sounds like. It's just, it goes over the hand, and it restricts kind of the dexterity significantly. So these are great for patients that are fine. They're not trying to get out of bed, but they're pulling IVs out and they're picking at things and pulling at the catheter and that kind of stuff. My only complaint and challenge with the mittens is people can quickly figure out how to get those off, and they're not as effective. You got to have a very specific patient for those. So those are a few examples of devices. But chemical restraints, they're different. And they're exactly what they sound like, a chemical. So they're given to stop, inhibit, or decrease a specific behavior that is dangerous to the patient. So these are meds, okay? 3 kinds that are typically utilized as chemical restraints. Benzos, typical antipsychotics, and atypical antipsychotics. So examples of some commonly used benzos utilized as chemical restraints: lorazepam, or Ativan, Versed. Those are some benzos. An example of an antipsychotic, Haldol, very common. Some atypical antipsychotics, Zyprexa, Geodon, Risperdal. So those are some examples of chemical restraints, but this is the most restrictive, absolutely most restrictive, because if you give it to somebody, you've got, it completely inhibits their behavior because they can't, they're knocked out, essentially. They're not unresponsive, but they're unable to kind of be awake, essentially. So there are risks, though. Absolutely, there are risks. So you don't want to do this unless someone is truly dangerous, a threat to themselves, or a threat to others. So it's really important. Honestly, I don't know if I've actually technically chemically restrained someone that was like super dangerous. I have had patients that were agitated, but they had increased ICP, and it was important for their medical stability to have Ativan, to have Haldol, but it wasn't like they were actively fighting me. If you're working in psychiatric units, you will see this a lot more often than myself, because typically there's other things going on causing issues. But there are risks. Respiratory depression, QT prolongation, and that can result in some other dysrhythmias. Extrapyramidal symptoms, those are a big one too. So you really need to know also if your patient has baseline dementia before giving these meds, because that can make it worse. Or are just not appropriate. So it's important to understand what their baseline status is before just hopping in and giving some chemical restraints. And again, these are the last result. You do not want to give these for someone that's mildly, anxious. There's other, things that we can do. And the kind of theme is do the least invasive interventions first. So we want to start, maybe if they're picking at IVs, let's try the safety mittens. Let's see how those go. If those don't work, maybe we can progress to the bilateral soft wrist restraint. Or maybe they're getting out of bed, running around and detoxing from alcohol and blah, blah, blah. I've actually used a posy enclosure bed where it actually literally encloses the patient in the bed, where they're not tied down. They can't get out of the bed because they're enclosed. There are 4-point restraints, which is only used absolutely necessary. Have not personally used that much in my nursing career at all. But again, if you work in the emergency department, you may see this. But you really got to use your clinical judgment when deciding what's the most appropriate. Does the patient have increased ICP, or do they have, oxygen demands and whatnot, where this agitation and this need for restraints is very high and we need to control it immediately? Maybe a hypertensive crisis, something like that. You want to ensure you're considering the patient's physical condition in your clinical decision making. It would probably be best to work with a physician to decide which option would be best, especially if you have someone who's very ill, not just mentally, but maybe we've got someone who's medically unstable. So you really got to work with the physician on what would be the least invasive but most effective intervention at that point. And one of the biggest things you've got to do with restraints is documentation. This is something that a lot of facilities are required to look at very closely and audit. The hospitals I've worked at, they look at your restraint documentation like a hawk. You're in there every 2 hours, releasing them from their restraints and moving them around and checking their skin and offering the bathroom and that kind of stuff. And then you're documenting it appropriately. This is really, really important. So that is some information about restraints. Working in a neuro ICU, I have used restraints many, 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 many times, and actually arguably more. No, I bet it's about 50-50 at the end of the day. If I'm working 2 weeks and I've got a couple, however many patients, maybe a third or a fourth of them are restrained. Just, when you're in that kind of environment, critical care has a lot more restraints than the floor and whatnot. So it's something I'm pretty familiar with, needless to say. So I hope this has been helpful. That concludes episode 78. Assess appropriateness of the type of restraint or safety device used.
This has been another episode of the unofficial NCLEX Prep Podcast. To get the massive PDF guide that goes along with this podcast, head over to nrsng.com/NCLEX Prep. That's nrsng.com/NCLEX Prep. That's a free download that you can take with you anywhere, and you can basically have this podcast in text format. Our goal here at nrsng.com is to give you the tools and the confidence that you need to succeed in nursing school, on the NCLEX, and in your life as a nurse. We want you to succeed, and we want you to become part of this movement of nurses that is dedicated and motivated to learning and becoming the best nurse that they can possibly be. My name is John Haas, RN CCRN, and I'm the founder of NRSNG.com, and I sincerely thank you for being here, and I'm so proud of you for taking this step in your journey. Now you know what time it is now. It's time to go out and be your best self today. Happy nursing.